Hi everyone. Today we're going to talk about fluid and electrolyte imbalances. So let's get started. Okay, so first thing we have to do is talk about body fluid and the way that the fluids make up, what part of the body are made up of fluids. So men and women are a little bit different. Women are about 55% fluid, where men are about 60%. And that has to do with muscle mass. Men typically have more muscle mass than women, where women usually have a little bit of a higher body fat content. So more muscle mass means that you're going to have more fluid. And the reason for that is because the muscle cells tend to hold more water than fat cells do. So it would stand to reason if you have more muscle cells, then you would have more water in your body. So now we also have to look at the composition of the fluids. So we have 2/3 of the fluids are intracellular, meaning inside the cell, and then 1/3 of our body fluid is made up of extracellular fluid, or fluid that lives outside the cells. So that would be, in the blood vessels or around the cells. So of this extracellular fluid, 80%, so most of it is made up of interstitial fluid, and that is the fluid that lives around the cells. Now, 20% of it is plasma, so that is in our bloodstream. So fluid balance is very closely linked to electrolyte balance, as we know. The normal fluid intake is 2 to 3 liters a day. That is food and fluid, so the fluid that you get in foods as well, that also accounts for that. Now, minimal urine output per day to show that we have, to properly excrete the waste products from our body is around 400 to 600 milliliters a day. Now, obviously, if we're determining are the kidneys functioning minimally, we're looking at about 30 milliliters per hour. But if we're looking to see are our kidneys functioning optimally, in the fact that are they able to excrete all of the waste products optimally, that would be 400 to 600 milliliters a day of urine. Then we have considerations about insensible water loss. So that would be water loss that isn't things like urination and things. It's more of things like through the skin or through the lungs. Like insensible water loss through the skin would be sweat. Insensible water loss through the lungs is just breathing. So you have to think, if you breathe or exhale onto a mirror or a window, what happens? You see fog, right? Well, that is because of water vapor. So when we breathe out, we lose water vapor. So if you have somebody who's breathing frequently or has a higher respiratory rate, they're going to lose more water or be at risk of dehydration. Typically, on a normal day, somebody loses about 500 to 1,000 milliliters in insensible water loss. So we lose half a liter to a whole liter of water every day just with insensible water loss in a healthy person. Okay, so you can see how that's going to increase significantly for somebody who is sick. Okay, so let's look at these solutions, IV fluids, and how they can affect cells. So let's start at the beginning with or in the middle rather, with isotonic. So isotonic solution is a solution that has a similar ratio of particles to fluid that the blood has, okay? That means that they, particles to fluid ratio is like 50-50, right? And now the blood, same way. So that means if you put an isotonic solution in someone's blood, it simply, boost their volume. It doesn't cause any kind of diffusion or osmosis to take place. It doesn't cause cells to shrivel or swell because the makeup is similar to the blood. So there's no movement in and out of the blood vessels with the isotonic solution. So isotonic solutions are great for patients who are dehydrated, low blood pressure type situations. those are the times that you would want to use isotonic solutions, because that will then just boost their volume in their bloodstream and thereby raise their blood pressure. So some examples of isotonic solutions would be things like normal saline, lactated ringers. Those are isotonic solutions. Now we also have hypotonic, and when we say tonic, just think particles, okay? So hypotonic means low particles. So that means that the concentration of fluid to particles in a hypotonic solution is less particles, more fluid. So that's what a hypotonic solution looks like. So if you were to put a hypotonic solution in the bloodstream, then the cells will see that there is a higher concentration of fluid than particles in the blood. So the cells will then say, okay, we've got to level things out, so I'm going to pull some of that fluid over into me, okay, to try to level things out in the blood. So now the cells are pulling fluid into them, and that causes the cells to swell because they're pulling fluid into them because they see that we've got extra fluid in the bloodstream, okay, so then the cells will swell. Hypotonic solutions are good for people who have cellular dehydration or people who have hypertonic blood. So people who have blood that is really concentrated with lots of particles and a little bit of fluid, sometimes a hypotonic solution is good in there as well. So an example of a hypotonic solution would be half normal saline or 0.45 normal saline. Okay, because remember, normal saline is 0.9. So, and that is isotonic. That's middle of the road. So if you get a solution that is got half of the particles of normal saline in it, okay, which is half normal saline, then that would be a hypotonic solution because that's half of the particles in it that normal saline does. And we know normal saline is isotonic. So half normal saline would be hypotonic, okay? And then we have the hypertonic solutions. So the hypertonic solution would be lots of particles, less fluid, as far as if you're looking at the concentration, okay? So you have a more highly concentrated solution there. Lots of particles, less fluid. The ratio is like that, okay? So what that means is when you put that into the bloodstream, now the cells look at that and they go, wow, we've got lots of particles over there. It looks like the bloodstream needs some more fluid. So let me give up some of my fluid into the bloodstream to even things out over there in the bloodstream. So what happens to the cells in response? The cells will then shrivel up, okay, because they're giving up their fluid. So they shrivel up kind of like a raisin, right? Now, hypertonic solutions are great for people who have cellular swelling. For example, a lot of times, somebody with edema in certain places or things like that, or cellular swelling, we would want to give the hypertonic solution. One thing of note is hypotonic solutions, these ones over here, hypotonic. Where would we not want to give those? Where would we not, what situation would we not want to give hypotonic solutions? Hypotonic solutions should not be used in people who have cerebral edema or brain swelling. What that can do is it can actually make the cells swell worse. And again, if hypotonic solution makes the cells absorb or pull in fluid and it's going to make the cells get bigger or swell, we do not want to give hypotonic solution to a patient who has cells that are already swollen. So this is why we would not give it to somebody who has, for example, a brain injury or cerebral edema. Some examples of hypertonic solution. This would be things like D5.5 normal saline, D5 normal saline, different things like that. Okay, and there are lists of the hypotonic, isotonic, and hypertonic solutions in your book. Okay, so let's move on to dehydration. Dehydration, also called fluid volume deficit. This is where we don't have enough fluid in our body. Okay, so anything that causes blood or fluid loss or poor fluid intake, those are things that are going to cause dehydration. Okay, anything that causes blood or fluid loss, or if you have poor fluid intake. For example, bleeding, makes sense, that's blood loss. Vomiting, GI suctioning, that's fluid loss. Diarrhea or laxative use, that's fluid loss. Diaphoresis, excessive sweating, that's fluid loss. Long-term NPO status, that falls into the fluid intake category. Trouble swallowing, eating, or drinking, that's fluid intake. Excessive urination, diuretics, that's fluid loss. And then fever, that's fluid loss. So fever kind of gets you in a couple ways. Number one, sweating when your fever breaks. But number two, oftentimes when people have fever, they breathe faster. So if you have somebody breathing faster, that's going to increase what? Somebody's breathing faster, that's going to increase what? That puts them at risk of dehydration. And the answer is insensible water loss through the lungs, right? Okay. Before I move on, one more thing I wanted to mention over here with dehydration. This is also called, can be called hypovolemia. Sometimes you'll hear it referred to as that. Women are more at risk than men. And again, let's think about that. What did we say? Women already have less body fluid, right? And we also said that women usually have a higher fat concentration in their body than men do. They have less muscle mass, so they're not able to store the fluid in their cells like men can. Okay, so women are more at risk. Older age, obviously, okay, they're more at risk. Obese patients, again, because if they have a higher concentration of body fat and less muscle mass, body fat does not hold water like muscle does. So again, that's why they'll say, like, when you go to work out and you gain weight, they say, well, you're gaining muscle. And muscle weighs more than fat because it holds on to water. It holds on to fluid. Okay, so let's move on to vital signs. Assessing. Weight loss. Let's talk about weight loss. We said that weight loss was the single best way to, or weight in general was the single best way to determine what? Weight was the single best way to determine fluid loss or gain in a human body, right? So it would make sense then that weight is going to be one of the best assessments that we can use to determine whether that patient has lost fluid, right? So weight isn't simply for fluid volume overload. You can also determine if somebody's lost fluid with weight. Think about any time that you've had a really bad, stomach virus, right? And we've had vomiting and diarrhea. We always lose a couple pounds from that, right? Because we're losing fluid. Usually it's about 1 liter of fluid is equal to about 2 pounds. Other things we're going to find: weak pulses, dizziness, flat neck veins. Let's talk about that. Weak pulse and dizziness, flat neck veins. Those all kind of go together because we have to say, what is the purpose of fluid in the body? Well, one of the big reasons we have fluid in the body is to increase the volume of our blood in order to maintain perfusion of our organs with oxygen, right? So the fluid kind of helps, carry the red cells and get the blood where it needs to go. It also increases the volume so that we can get good perfusion pressure and good blood pressure. So if you have a patient who does not have a good amount of volume in their bloodstream, then their pulses are going to feel weaker, because when you feel a pulse, you're feeling the pressure on the vessels. If the patient doesn't have a good volume, they're not going to have good pressure, and that means you're not going to feel a good pulse. Dizziness, the brain's not getting perfused very well, right? So that's why we would have dizziness. Flat neck veins, obviously you need volume to make the veins feel supple. So if the veins do not have good volume in them, you're not going to feel them as much. That's why they always tell you before you go to get your blood drawn to make sure you drink fluids so that they can, that'll beef up your veins for them to be able to find them easier to draw your blood. Dry skin, mucous membranes. So obviously we've talked about this before. If somebody's dehydrated, their body is not going to send fluid to the non-essential areas. Their body is going to maintain the fluid in the bloodstream, and it's going to make sure that the vital organs get perfused. So unfortunately, skin is not really considered a vital organ. And mucous membranes as well. So if we are dehydrated, our body is not going to send fluid to those areas and keep them moist. Okay. Poor skin turgor, again, that kind of goes along with that. The body is not going to, if it has no fluid to spare, it's not going to give any to the skin. Okay. Change in level of consciousness, confusion, that kind of goes along with the dizziness. The brain is not getting perfused if we don't have the perfusion pressure to get the blood and oxygen up there. And again, if we don't have volume, we're not going to have pressure. Decreased urine output, this has to do with the kidneys not giving, so the kidneys, when they don't get perfused with a decent amount of volume, then they activate the renin-angiotensin-aldosterone system. This system basically activates aldosterone, and it causes a retention of water and salt. So basically, the kidneys say, okay, I have low volume coming to me. I'm going to activate this system that basically helps me keep water and salt so that I can maintain blood pressure and perfusion to our vital organs. So decreased urine output in somebody who has dehydration tells you that the kidneys have activated the RAS system and that the kidneys are doing their best to try to compensate and maintain homeostasis. Now let's look at vital sign changes here. So for the vital signs, we have tachycardia, okay? So if the heart, if the volume has dropped in the bloodstream, then the heart is going to beat faster to maintain the same amount of cardiac output, okay? Because cardiac output is heart rate times stroke volume. So if the volume has dropped, then the heart rate has to make up for the difference, okay? So that's why when somebody has dehydration, they're going to become tachycardic. It's compensation. The body is compensating for their weak areas by beefing up other areas. Okay, hypotension, obviously blood pressure is affected by fluid volume and constriction of vessels. Here we lose volume. Okay, orthostatic hypotension is almost always caused by some kind of fluid imbalance or fluid volume deficit. So again, same thing here. Increased respiratory rate, again, if our body does not have the volume to oxygenate appropriately and perfuse appropriately, the body's going to compensate by increasing the respiratory rate, saying, okay, we're obviously not able to perfuse properly, so let me oxygenate as much as I possibly can. So what is getting perfused is well oxygenated. Okay, so that's why the respiratory rate goes up. Low-grade fever, that oftentimes tends to happen with dehydration as just part of the stress response. Okay, now a little bit about, one thing I forgot to mention about weight is that we say about a half a pound a day is considered fluid loss. So if a patient's losing, like if you're checking their weight every day and they're losing like a half a pound every day, that's considered fluid loss. All right. And remember, when you're checking skin turgor on an older adult, you're checking it on the chest. Okay, now let's look at the labs. We're gonna assess for dehydration in the lab values. So the reason I put this these glasses of iced tea up here is to explain hemoconcentration versus hemodilution. So you can see here, if this were blood, this over here would be the blood of a dehydrated patient, because if you can see, it's more concentrated with T particles, okay, in this over here. So this volume here. This is more concentrated with T particles, so this would be what a dehydrated patient's blood would look like because it's got more particles and less fluid. Okay, so some examples of some labs that we're going to see here. Hemoglobin and hematocrit are going to look elevated. Serum osmolarity, that's basically the concentration of particles in the blood. Serum osmolarity is going to go up because the blood's more concentrated. BUN, that's by itself, without the creatinine, really helps us to understand what's going on with fluid volume in the body. So BUN, when it's elevated, that means the patient is dehydrated. And then urine-specific gravity is how concentrated the urine is. So like we said before, when volume is low in the body, the kidneys will activate the RAS system, and that will tell the kidneys, okay, hold on to water and salt. Don't get rid of it. So here we have a situation where we're not going to be putting out a lot of urine, and what urine does come out is going to be concentrated because the kidneys are holding on to a lot of fluid. So the urine coming out will be concentrated. That is going to increase specific gravity. So make sure you understand and know these lab values. If they are located in your Galen lab values, make sure you make flashcards and know these. Okay, so let's keep moving on here. Oh, and also, another way to remember this is most of the time, now it's not always true with electrolytes. We're gonna keep those to the side. But for the most part, these labs here, remember, when the patient's dry, the labs are high. Okay, these labs here. Okay, so how do we fix dehydration? Well, if the patient can tolerate fluids, if it's not because of a GI issue, we can offer oral fluids and ensure intake at least every 2 hours. We're going to offer them things that they like. We want them to drink about 60 to 120 milliliters every hour. You're going to keep assessing that patient during the rehydration. You're going to assess their pulse rate and their urine output. So our pulse rate and quality, right? We're going to see, is their tachycardia decreasing? Is their pulse feeling stronger? Are they making more urine? These are all the things we're watching out for. And that is the E in ADPI. That's us saying we've assessed, we've determined a plan, we've executed that plan with interventions, and now we are going to evaluate and say, did our plan and our interventions work? Okay, so that's what assessing them or reassessing them every 2 hours is doing. IV fluids are also a possibility, and you always want to treat the cause if you can. Because you have to think, if you have somebody who's dehydrated and you simply are putting IV fluids in them or oral fluids in them, and you're not treating what caused it to begin with, that's like putting water in a bucket full of holes. You can keep putting the water in there, but if you don't fix what caused the dehydration to begin with, they're just going to keep losing the fluid. So treat the cause, whether it be, an antiemetic, an antidiarrheal, get them in from outside so they're not sweating anymore. You kind of have to figure out what's causing it. A lot of people question, well, when do I give oral fluids versus when do I give IV fluids? One thing to remember is the intensity of your intervention is going to depend on how severe the client's symptoms are, okay? The intensity of your intervention is going to be determined by how severe the client's symptoms are. So if you have somebody that comes in with hypotension, tachycardia, decreased level of consciousness, dizziness, confusion, all these things, or maybe their labs are really high. This would be somebody that you'd want to treat with IV fluids. You want to be a little more aggressive. Now, if you have somebody that comes in who is, been working outside for a few hours and got a little bit dizzy, but blood pressure is maybe a little low but stable, a little tachycardic, but still alert and oriented, that person, you may want to say, okay, let's do some oral rehydration and see how you do for a while. So you have to say, how fast are they going to go south on you? How fast is it going to take them, or how long is it going to take them to, really start to have a lot of problems? If you have somebody whose blood pressure is already in the tank, you don't want to wait around for PO fluids to get absorbed. You want to treat a little more aggressively with IV fluids. Okay, next we're going to talk about fluid volume overload. This is also called hypervolemia, or what's another word? Hypervolemia, fluid volume overload, and those are the only ones I can think of right now, so we'll go with those two. All right, so categorically speaking here, we're talking about excessive fluid intake or anything that causes the body to retain fluid. So let's look at what some of these may possibly be. So obviously if we're taking in too much fluids, or more likely than the water intake, although that could happen, more likely it's going to be IV fluids, okay? IV fluids, those can cause fluid volume overload very quickly, especially in what type of patient? What type of patient can IV fluids cause fluid volume overload very quickly? Okay, we have to pay really close attention to our cardiac and renal patients, okay? And look at it's right here, cardiac and renal. Blood transfusions. So we talked about this and we talked about blood products. One of the number one things that we have to worry about in patients getting blood products besides a transfusion reaction is circulatory overload, okay? Renal failure. One of the biggest jobs of the kidneys is to regulate fluid volume in the body. If it is failing, if the kidney is failing, it cannot do that job. And so the kidneys will retain fluid. Heart failure. So while kidneys regulate volume and say, okay, the kidneys can hold on to or let go of fluid, right? Heart failure, the heart's job is to propel blood in a forward motion, forward direction, right? So if the heart is failing, it can't do its job. If its job is to propel blood in a forward motion, and it can't do that, then the blood's going to back up. Now the problem with that is that the fluid can't make it to the kidneys, okay? So then the kidneys say, we don't have enough fluid happening or coming to us. We don't have enough volume coming to us, so we are going to hold on to more fluid. And so what happens is you have a pump that does not adequately pump fluid to the kidneys, so the kidneys activate the RAS system and hold on to salt and water, okay? That's why one of the number one things you teach patients with heart failure is fluid and salt restriction, because the kidneys are holding on to it, okay? So heart failure can cause fluid volume overload, kidney failure, blood transfusions, IV fluids. Let's talk about cirrhosis. Cirrhosis, when you have cirrhosis, one of the things your body can't do is it can't make albumin. And albumin is a fluid magnet. We talked about that with the blood products, remember? And so when somebody has a lack of albumin, then they have a really hard time keeping fluid in their bloodstream. It goes into the interstitial spaces, right? So when it goes into the interstitial spaces and the patient drinks more fluid, and then that fluid goes into the interstitial spaces, so that patient is just retaining more and more and more fluid. And so this is why you'll see cirrhosis patients that have, the big ascites, the big bellies, or they will have, edema of their feet or their hands, and that's because they don't have a good amount of albumin. And then long-term steroid use. Steroids are known to cause fluid retention, okay? So that's another thing we have to make sure we pay really close attention to. Okay, so assessing for fluid volume overload, what are we looking for? So let's talk about these assessment findings over here. First, bounding pulses. So again, if feeling a pulse is feeling the amount of pressure on the artery, okay, then if we've got lots of fluid, we're going to have a higher pressure. So that is going to cause a bounding or very strong pulse. Vein distension, again, so if volume is what causes the veins to distend. This is a lot of volume, so you're going to have venous distension. Weight gain, obviously we're retaining fluids, so we're going to retain weight. And again, daily weights are very important. Dependent edema. Remember, edema is mostly going to happen via gravity, right? So wherever gravity is pulling, that's kind of where the fluid's going to go. So that's why you'll see pedal edema a lot, because people will sit with their feet down. Change in level of consciousness. So this has to do with hemodilution. So while we have a good amount of volume going into the tissues, the concentration of red cells in that volume is down because of how much volume we have, right? So again, instead of having a good concentration of, red cells to fluid like this, we end up having lots of fluid. Okay, so it looks like the red cells look lower. So when that perfuses to the brain is not getting enough oxygen, and that's why we get that change in level of consciousness. Shortness of breath on exertion and crackles, that has to do with hydrostatic pressure. So remember how we spoke that vessels under pressure leak, especially veins and capillaries. When they get under pressure, they leak. And so if you guys remember the picture of the alveoli, and we say that, the capillaries surround the alveoli, that's how gas exchange takes place. So if those vessels are full of fluid due to fluid volume overload or hypervolemia, then what happens is that fluid will leak out of the vessels and into the adjacent tissue, which happens to be the alveoli. And we end up with pulmonary edema, which manifests as shortness of breath and crackles. Now, if we look at vital sign changes here, tachycardia, obviously now you would think, wouldn't they go bradycardic because they got tachycardic and dehydration? But here's the thing. They're going to go tachycardic because, again, the body sees that we don't have enough oxygen because of hemodilution. So we're going to be tachycardic because of that. Elevated blood pressure because of the volume. And respiratory rate, again, because of the lack of oxygen and the shortness of breath. Both of those things. Okay, let's take a look at the labs. So with the with the labs here, again, we put another iced tea picture up here, but we see this time we've circled the lighter iced tea because people with fluid volume overload are often hemodiluted. And here you can see that this iced tea is very diluted, okay? So hemodilution happening here. So hemoglobin and hematocrit are going to look low, okay? And BUN is going to go down because, again, we said by itself, without the creatinine, it kind of shows us fluid status in the body, okay? So H and H are down, BUN is down. These are things that we have to look out for. So one example is you have patients that come into the emergency department with dehydration, and they get a fluid bolus in the emergency room. Their hemoglobin and hematocrit, maybe was on the high end of normal when they came in because they were dehydrated, right? So now they get, a liter of bolus in the ER, and then they come to your unit and you check their labs the next morning. And you see that their hemoglobin and hematocrit have dropped like a full point, right? And so, when I first started as a nurse, I saw that and I would be like, are they bleeding? I don't understand. And then after time, I realized, and I was taught and educated by a lot of good coworkers that, this is all due to hemodilution. So if somebody comes in hemoconcentrated with a hemoglobin and hematocrit that are, on the high end of normal, and then you give them a bolus of fluid, well, that's going to dilute their blood a little bit. So obviously their H and H are going to drop a little bit. So we always have to keep that in the back of our minds. If you're ever looking at a patient that, reviewing their labs and you say, oh my gosh, they dropped a gram on their H and H, what's going on? that's when you would say, okay, they just came from the emergency department. Did they get a bolus down there? Could that possibly be what it is? Obviously, if they have overt signs of bleeding or they're here for a GI bleed or something like that, that's different. But if they've just come in with dehydration, or gastroenteritis or something like that, look and see if they got a bolus in the emergency department. Okay, treating fluid volume overload. So here we have our handy dandy furosemide, because obviously that's the best way and probably the most aggressive way to treat the fluid volume overload. But again, we're going to be assessing this patient every 2 hours because fluid volume overload can get bad. It can be very life-threatening. Dehydration as well. Fluid volume overload, what assessments are we doing? The most important assessment to do is going to be listening to those lungs. Okay, lung sounds are the ultimate, because lung sounds or crackles, pulmonary edema, is how you die from fluid volume overload. Okay, that's the quickest way. So we're going to listen for those crackles. We're going to watch for any worsening symptoms like a change in level of consciousness, increase in tachycardia. We're going to watch for electrolyte imbalance due to that hemodilution. Now, as we give diuretics, we're going to continue to watch those electrolytes because we want to make sure that we're not causing an electrolyte imbalance because of the diuretics. As we know, loop diuretics can be very aggressive with the electrolytes. Loop diuretics, remember, furosemide causes a ferocious tide. So furosemide will wash the body of fluids. Okay, it will rid the body of fluids, but the electrolytes go with it. So we got to monitor those electrolytes when we have somebody on diuretic therapy. We also want to make sure we're not overcorrecting, and we don't want to give them so many diuretics that they actually go into dehydration. Head of the bed at 30 to 45 degrees. Why do we think that is? Why do we think that 30 to 45 degrees is so important? Somebody with fluid volume overload is going to have a hard time breathing. They're not going to want to lay flat. So you want to keep the head of their bed up a little bit so that it can help with the lung expansion. Okay, we want to get as much of the alveoli full of air as we can. So let's talk a little bit about patient teaching. What kind of patient teaching points do you think? So I want you to take a second and think about what you would teach a patient with fluid volume overload if you're going to send them home. So first of all, we're going to say, when do you call the doctor? We're going to call the doctor if we have a weight gain of 3 pounds in a week or 2 pounds in a day. Okay? Also, we want to make sure that, remember, for daily weights, you want them to just be mindful that only about a half a pound a day can be due to actual metabolic reasons, like actual weight gain, right? It's not fluid. So 3 pounds in a week, 2 pounds in a day, we got to watch out for that. Now, as far as salt and fluid restrictions, that's going to be a little more patient specific, but that is something that we would teach them to regulate their salt and fluid intake. It depends on the severity of the fluid volume overload as to what the restriction's going to be. A typical restriction for salt is around 2 to 4 grams a day. Is how much they want. Okay, now we're going to move on to the electrolytes. So one thing I want to talk about here is the nightclub rule with electrolytes. And just kind of an overview of what electrolytes do. Because remember, one of the best ways to truly understand this med-surg nursing content is to start from the beginning and say, what is happening when things are going right? So if we look at the electrolytes, we see that we have sodium and potassium and calcium and mag. Those are the 4 major players. Those are the 4 main characters in our story, right? We've got chloride and phosphorus. They're kind of like supporting actors. But we're going to say sodium, potassium, calcium, and mag. Those are our main players. So for somebody, for sodium and potassium, their role in electrolyte balance or in the body is they are the exciters and communicators. So they are the guys who kind of stimulate the muscle membranes and kind of get them moving, or kind of, communicate with them. Calcium and magnesium, they're the regulators or stabilizers. So they're there to keep everything calm. Okay? So if we use the nightclub analogy here, we can see that sodium and potassium are probably going to fall more into the DJ category, right? They're there to keep the party going. Now, calcium and mag are going to fall more into the bouncer category. So they're going to be the big guy over here because they kind of keep things stabilized and regulated. Now, this concept is going to come into play, especially when we're talking about symptoms. So you'll see that shortly. Okay, so the first one we're going to talk about is sodium. Sodium, low sodium is called hyponatremia. So here are our causes and risk factors. Obviously, sweating. We all know when we get like sweat in our mouth or whatever, it's salty, right? So excessive sweating, we're going to lose salt. Diuretics, especially loops and thiazides. Loops and thiazide diuretics. So loops, that would be furosemide, bumetanide, and then the thiazide diuretics like hydrochlorothiazide. They're going to lose, they cause sodium loss. If the patient is NPO or on a low salt diet, we can actually cause hyponatremia. Excessive fluid intake is going to cause hemodilution, okay? And that can cause hyponatremia. And then kidney disease. So if a patient has issues with the kidney, remember the kidney regulates fluid and electrolytes. So if it is diseased, can't do its job, can't regulate sodium. So you can end up with low or high sodium, depends. So symptoms of hyponatremia. So when somebody has hyponatremia, there's two big reasons why they have symptoms. One is because obviously we talked about sodium being a muscle membrane exciter or a communicator, right? The other reason is sodium's special and close relationship that it has with water, okay? So if we look at hyponatremia, when somebody has a low concentration of salt in their bloodstream, okay, then it's going to look like salt, water, right? That's what it's going to look, the blood is going to look like, salt, water. So if that happens, then the cells are going to see that and they're going to go, there's too much fluid over there. Let me pull some of that fluid into me to try to level things out. Well, the problem is then the brain cells do that and they swell. So when the brain cells swell, then you end up with malfunctioning brain cells. And this is what leads to level of consciousness changes and confusion. And then when it gets severe, you can see the picture here, seizures. Seizures are a major, major concern, and obviously coma and death to somebody who has hyponatremia, major. And then we also have decreased cell membrane excitability. So if sodium is the exciter and the communicator, if sodium is not there enough to excite or communicate, then you're going to end up with muscle weakness and diminished deep tendon reflexes. Let's take a look here at a couple other things. When you're looking at the electrolyte rule here, or this little electrolyte analogy, one thing you want to keep in mind is this is just a general rule. There are symptoms of electrolyte imbalance that don't follow this rule, but for the most part it does, especially when you're talking about skeletal muscles. It mostly does. So again, potassium and sodium are the exciters, and so if they are not there, then things are going to be low and slow because the exciters aren't there. If they are there too much, then things can get too excited, and they can actually get so excited that they can kind of stop responding, and we'll talk about that soon. Over here with the calcium and mag, remember they're the regulators and stabilizers. You have to think, what would happen at a nightclub if there's no bouncers there? Okay? If they are not there to regulate and stabilize, then things are going to get out of control. So you get the twitchy, tingly, excitable symptoms, right? If you have too many bouncers at a nightclub, well, then it kind of be boring, right? So if you have too much mag or calcium, what you'll see is things get suppressed and they get low, slow, and depressive type symptoms. So again, let's take a look at this hyponatremia. And we said that, oh, hold on just a second here. We said that, there we go. We can have the decreased deep tendon reflexes and muscle weakness, and that is because the exciter is not there. So let's look about how we treat hyponatremia. Treat the underlying cause. Again, if you can figure out what's causing it, fix it. And that's true pretty much for all fluid, electrolyte, and acid-base imbalances. If you can figure out what's causing it, fix it. Diuretics. Remember, furosemide creates a ferocious tide. So if you got diuretics on that patient, hold them. You do not want to give the diuretics to somebody who is hyponatremic. Hypertonic IV fluids and tolvaptan. So these are two things that we have to consider the fluid status of our patient before we decide which one of these we're going to give. Because one of these will give fluid and one of these will take it away. So hypertonic IV fluid, 3% or 5% saline. Remember, we said that normal saline, which is 0.9, okay, that's less than 1%, 0.9% normal saline. That is isotonic, okay? This is hypertonic because this is almost like 3% saline. That's almost 3 times the amount of salt as normal saline. So that's going to be a higher concentration of salt particles. So hypertonic 3% or 5% saline, that is going to replenish the body with salt, but it's going to do it with fluid also. So if you have somebody who is hyponatremic due to excessive fluid intake, fluid volume overload, and hemodilution, this is probably not the best option for you to do. This is going to be for somebody who, was excessively sweating outside and lost water and salt together. This would be a good option for them. So for somebody who is dehydrated and has hyponatremia, this would be the way to go. Fluid volume overload, you wouldn't want to do this one, okay, because you're going to add more fluid using this method here. Now, tolvaptan. Tolvaptan is in a category of drugs that has the ability to pull water out of the body through the kidneys without pulling the salt. So we can see that tolvaptan would be a good choice if you have a patient who is hyponatremic due to hemodilution. If they're hyponatremic due to hemodilution, let's give them a drug that pulls the water off without pulling off the salt. Because then we've got salt, water. If you give them tolvaptan, guess what's going to happen? Okay, we're going to bring it back down to normal. But again, you would not want to give tolvaptan to a patient who is hyponatremic and dehydrated. Okay, so you have to consider fluid volume status before you determine which of these would be the appropriate action. Seizures and fall precautions, because sodium is a regulator. Sodium's an exciter, right? So if sodium is not there, then we can end up with falls because of weakness. And remember, again, so seizure precautions, because this patient with hyponatremia is at risk for seizures because swollen brain cells do not do well. They do not do well. Patient teaching. So what are we going to teach this patient? We're going to teach them about increasing the salt in their diet. How often do we get to say that, right? Increase the salt in your diet. Go eat a bowl of Campbell's soup, right? Go into the frozen food section and get all the TV dinners. Lots of salt. Have a bowl of ramen noodles. High salt diet. Decrease fluid intake. So again, that would probably be dependent upon why they were hyponatremic. If they were severely dehydrated and hyponatremic, we may not want to advise that. So that would also depend on why they were hyponatremic. Hypernatremia. So now we're going in the other direction and we're talking about high sodium. So some causes of high sodium. Kidney failure. Again, if the kidneys cannot function correctly, they cannot regulate electrolytes, okay? Corticosteroids, corticosteroids cause salt and water retention. So they're a risk factor for fluid volume overload and hypernatremia. Then we have obviously excessive PO or IV sodium intake, and you can see the excessive PO intake of salt here in the picture. And dehydration. So dehydration can cause hypernatremia due to hemoconcentration. It depends on why they got dehydrated again. Hypernatremia symptoms. So this girl here is agitated. So this is agitation. They can also have confusion. But now wait a minute. How many of you are starting to get confused? Because look back here. Confusion. So we have confusion for both hypo and hypernatremia. Why do we think that is? That is because when somebody has high salt in their bloodstream, then we have high salt, low fluid. So the cells look at that and they go, uh-oh, we need more fluid over there in the bloodstream. Let me give up some of my fluid to try to even things out. And now the cell goes like this, and it shrivels up. So now we have a shriveled up brain cell. Shriveled up brain cells don't work any better than swollen brain cells do. So that's why whether you're hypo or hypernatremic, brain cells swell or shrink. Okay? Hyponatremia, they swell. Hypernatremia, they shrink and shrivel. Both of those types of brain cells do not function well. Brain cells function well when they are in normal size. If they're shriveled up or if they're swollen, they don't function. And that's why you can get confusion and agitation with, you can get neuro symptoms with both. Now, the worst of the two, if I had to pick, would probably be hyponatremia, because if the cells swell too much, they can poof, they can burst, okay? And they can break apart and die. So, and that's where the seizures, coma, and death come into play. And that's why hypo is probably a little bit worse as far as the neuro symptoms go. Let's focus on hyper here. So we said confusion and agitation because of cellular shrinkage. And then we also have the muscle excitability factor here again. And that is the twitching, the twitching, which is the excitable, right? Because sodium's an exciter. So if we have too much sodium, too much excitability, we get twitchiness. But here we see weakness and decreased deep tendon reflexes. Now, wait a minute. Didn't we see that over here? Let's look at this here. Yes, we did. We said we saw, hold on just a second here. There we go. There it is. Weakness and decreased deep tendon reflexes. So why would we have that with both hypo and hypernatremia? So with hypernatremia, we said sodium's an exciter. So if we excite too much, we can get overstimulated. Let's think about that. Let's go back to that analogy of the bouncers and the DJs at the nightclub. If you have DJs that are just crazy out of control and are, you know, really, really having a big party, eventually the patrons of that club are going to get exhausted and they're going to start passing out, right? They're going to get overheated. They're going to get exhausted. Same thing happens to muscle membranes. Eventually, muscle membranes cannot respond anymore because they are so overstimulated. Okay, so that law of overstimulation can happen. When somebody has too much sodium or the sodium rises too fast, you can end up with decreased deep tendon reflexes and muscle weakness because the cells are overstimulated. Okay, so basically we go, sodium's going up, we're getting twitchy, and then the sodium goes up, and the patient cannot respond anymore. Okay, so that's why we can get these weakness and decreased deep tendon reflexes with somebody who's hypernatremic. How do we fix hypernatremia? Well, we fix it again, treat that underlying cause. Then we have, again, we have to determine our fluid status of our patient as to what we are going to do. So if the hypernatremia, if the patient is dehydrated, then we can give normal saline or D5.5 normal saline. Okay? If the patient is dehydrated, if the patient is fluid overloaded, then we would give diuretics, furosemide or bumetanide, one of those two. So again, if they're dehydrated, give them fluids. If they're overhydrated or hypervolemic, give them diuretics, and that'll take care of it. Encouraging fluids is going to be obviously if the patient was dehydrated, and then a low salt diet, obviously. And again, we want to be very careful when we're correcting sodium in either direction, okay? We want to be very careful because we want to correct sodium slowly. And often physicians will correct a little bit and then they will check. They'll say, okay, I want you to do this, and then I want you to check a sodium in 4 hours. And then do this, check a sodium in 4 hours. So they want to raise the sodium or lower the sodium slowly, because you have to think, if you do it too quickly, then the cells are going to react to that and it's going to cause a fluid shift, okay? And so if you treat hypernatremia, or if sodium is corrected too quickly, it can actually cause issues with the brain cells, okay? So that's why we want to make sure we do it slowly. Okay, moving on to hypokalemia, or potassium in general. Remember, it's an exciter along with sodium. Hypokalemia causes and risk factors. So diuretics, obviously, we're going to lose potassium with diuretics, especially the loops and the thiazides again. We would not lose them with the potassium-sparing diuretic, obviously, but the loops and thiazides we would. NPO, low potassium diet, excessive fluid intake due to hemodilution, diarrhea, we lose potassium, and vomiting and NG suctioning are all things in which we lose potassium. A couple other things, something like too much insulin. So if somebody gets too much insulin, the thing with insulin is it puts glucose into the cell, but potassium likes to sneak in right behind the glucose. So if you have somebody who has like an insulin drip, for example, if they have insulin going IV in a drip form, what can happen is the patient can develop hypokalemia because the potassium's going into the cell behind the glucose, and that will leave the bloodstream low on potassium. Another thing is corticosteroids. Again, those can raise salt and potassium. Just it depends on the dose and things like that. So these are all things that can cause an issue with that. My apologies. Corticosteroids will lower potassium. I'm sorry. So corticosteroids often mimic aldosterone. And so aldosterone holds on to salt and water, but it kicks out potassium. And so corticosteroid use can actually cause hypokalemia. So we got to watch out for that. All right. So again, here, let's look at these symptoms of hypokalemia. So we are looking at things like shallow respiration. So let's think about why that is. Why would somebody with low potassium have shallow respirations? Think about potassium stimulation of muscles. Look at right here, muscle weakness. So if somebody has a low potassium and the potassium is not there to excite their skeletal muscles and talk to them, communicate, and tell them to move. So what happens then, we end up with shallow respirations and weak muscles because remember the diaphragm and intercostals are muscles, so they can cause shallow breathing when they're too weak to move, right? So breathing is a major consideration for somebody if they have hypokalemia. Weak pulses, absolutely. Orthostatic hypotension, yes. EKG changes, absolutely. Constipation, abdominal distension, these are all things that can happen. Nausea, vomiting, because again, the potassium's not there to stimulate, and so the GI tract doesn't want to move, and then the vomiting will happen because the GI tract doesn't want to move. So nothing's moving forward, it'll all just kind of hang out in the stomach, and the stomach it'll come right back up. So these are all things that can happen to the patient. If the hypokalemia gets severe, the diaphragm can actually become flaccid where it doesn't work at all, and then that patient will need to be intubated, okay, and put on a vent. All right, let's keep moving here. Let's talk about hypokalemia and digoxin toxicity. So digoxin is a cardiac drug that works to help the heart beat stronger and more steady. So the thing with dig and potassium is, here, this is my kind of representation of what happens. So basically, dig and potassium, potassium has parking spots in the cell, and dig likes to fill up those spots when potassium's not there. So basically, this would represent like a cell with hypokalemia. We only got one potassium parked here, right? So what's going to happen is digoxin's going to come along, and digoxin is going to park in all these empty spots because potassium is not parked there. So you end up with dig toxicity in hypokalemic patients because the digoxin is able to kind of basically park itself in the cell and not leave the body. And so it'll just park and stay, and then the patient takes another dose of dig, and it will park and stay instead of being excreted by the kidneys. So it basically kind of hangs out there and will start having bad effects on the body. So digoxin toxicity is a major concern in patients taking dig who have hypokalemia. So if you have somebody on dig, watch their potassium. Okay, how do we treat hypokalemia? There it is again, treat the cause. Potassium can be lost with diuretics, so hold it. Hold those diuretics if the potassium is low. Except for the potassium-sparing diuretics. You can give those, but don't give the loops or the thiazides. And an example of a potassium-sparing diuretic is spironolactone. SP for sparing, SP for spironolactone. Fall precautions, because again, if the patient's potassium is not there to stimulate, then the patient will be weak. They can fall. Fall precautions. Potassium supplements are good. Increased potassium intake. IV potassium can be used as well. And we'll talk about that in a second. And again, ultimate importance, respiratory and cardiac assessments. Both are of equal importance. Both can be pretty significantly affected by hypokalemia. Okay, another little, tidbit of information is if magnesium is low as well, potassium treatment won't be as efficient. So when you are treating hypokalemia and you're treating with potassium supplements, make sure that you treat the low mag as well so that the potassium treatment will work. Now, treating with IV potassium. There's a couple of things. First of all, never give potassium IV push. Never. Okay? That will raise the potassium too fast in the body. When we raise potassium too high, too fast, what happens is those cells become overstimulated and won't respond. And we'll talk about what those symptoms will look like in a few minutes. But basically, you can stop a patient's heart by giving potassium IV push. So you will never see vials of potassium on a nursing unit, ever. You won't see them. 5 to 10 milliequivalents per hour is ideal. That's where you want to be, okay? No faster than 20 milliequivalents per hour. Now, what that means is usually the 20 milliequivalents is through like a central line, okay? 5 to 10 is usually where you want it for a peripheral IV site. You want to monitor that site every hour for phlebitis and infiltration. Potassium is very, very painful if it gets infiltrated. It's painful when it's not infiltrated. So if it gets infiltrated, it can be really painful. So we really have to monitor that closely. Now let's move on to hyperkalemia. Again, with the kidneys. Certain medications. So obviously, if we said that we can give spironolactone to hypokalemics because it spares potassium, then it would make sense that you probably wouldn't want to give a potassium-sparing diuretic to a patient with hyperkalemia because it's going to hold the potassium even more. Now, another one that can cause hyperkalemia is ACE inhibitors, angiotensin-converting enzyme inhibitors, that drug class. The reason for that is because ACE inhibitors activate aldosterone. Or sorry, no, they don't. They inhibit, rewind, they inhibit aldosterone. So ACE inhibitors actually inhibit aldosterone. So what happens is aldosterone doesn't happen. And aldosterone is supposed to hold on to water and salt and kick out potassium. If you're giving a drug that inhibits aldosterone, then the body cannot kick out potassium. It can't get rid of potassium. Okay? So if you give ACE inhibitors, you can actually inhibit the body's ability to get rid of potassium. So ACE inhibitors and potassium-sparing diuretics like spironolactone, those are the two main types of meds that can cause hyperkalemia. Excessive PO or IV potassium intake, obviously, and salt substitutes. Salt substitutes are full of potassium. That's why we say if you have a patient who's taking an ACE inhibitor for blood pressure, but they're also trying to avoid salt, we want to tell them use herbs and spices. Do not use a salt substitute, because ACE inhibitors plus salt substitute will definitely lead you to hyperkalemia. Some other things that can lead to hyperkalemia: traumas and burns. Traumas and burns. 90% of potassium lives inside the cell. Traumas and burns destroy cells. When cells are destroyed, they break apart and release their contents into the bloodstream. So trauma and burns will destroy cells, and they'll release potassium into the bloodstream, causing hyperkalemia. Also, massive blood transfusions. So lots and lots of blood transfusions sometimes can raise patients' potassium level. And acidosis. So if somebody has acidosis, you have to watch for hyperkalemia. And we'll talk a little more about that later. Symptoms of hyperkalemia. So obviously those EKG changes. We can get bradycardia and hypotension. Now a thing with this is if potassium rises too fast or too high, we can go from bradycardia and EKG changes to cardiac arrest. Okay, so we have to watch out for that. Also, because potassium's an exciter, we got to watch for the twitching and tingling and diarrhea. As far as the EKG changes up here, one thing that you'll see are tall tented T wave. So that would be where you have the P, QRS, and then the T is the last little hump in the in the EKG complex. That last little hump would be spiked and tall, and that is a sign of hyperkalemia. So how do we fix hyperkalemia? Well, we definitely want them on a cardiac monitor, because if they cannot be monitored, we won't be able to tell if they have any dysrhythmias, and those dysrhythmias can be life-threatening. Fix the cause. Give them diuretics, except for potassium sparing. Don't give them that. Sodium polystyrene sulfonate, sometimes just called polystyrene. Kxalate is the brand name. That is a drug that will pull potassium out through the stool. So the patient can take it orally or via an enema, and then it will cause the patient to stool, and it will pull the potassium out that way. Now, another thing is insulin and dextrose. So we said that an insulin drip can cause hypokalemia. Remember? We said an insulin drip can do that because, there it is. Okay, so we have the cell and we have the insulin train, and it puts glucose into the cell, right? That's its job. That's what insulin's job is. But potassium likes to be a stowaway on that train, hop on behind it, and follow glucose into the cell. So this is why if somebody has hyperkalemia, one way we can fix it is to give them insulin. Now, insulin will not rid the body of potassium. It simply shifts it out of the bloodstream into the cells. So insulin is a quick fix. It will definitely get the potassium out of the bloodstream quickly, but it won't solve the problem long term. It's just a short-term fix, kind of like a Band-Aid, right? So what we would need to do, a lot of times doctors will give IV insulin and dextrose, and then they'll follow it up with the polystyrene to try to rid the body of that potassium once it comes out. Here's the thing, though. Polystyrene, or Kxalate, that works slowly, okay? So if you have somebody, remember we said the severity or the aggressiveness of your treatment depends on the severity of the patient's symptoms. So if the patient's having some pretty significant symptoms like EKG changes and things like that, you probably want to go with the insulin because the insulin will solve the problem or it will treat the problem quickly. But then as that potassium wants to shift back out into the bloodstream, if we have taken the polystyrene with the insulin, then what will happen is when that potassium shifts back out into the bloodstream, the polystyrene is now absorbed into the bloodstream and is able to grab that potassium and get rid of it. Okay, so that's why you'll see doctors do kind of like a dual type treatment there. Now, why do we give the dextrose after the insulin? Dextrose is given because, not every patient with hyperkalemia also has hyperglycemia. So when you give insulin, you're going to pull the glucose out of the bloodstream too, not just the potassium. So then we follow up the insulin with dextrose, which will kind of replenish that glucose into the bloodstream so that the patient doesn't become hypoglycemic. And then obviously hyperkalemia, because the muscles will be weak, because again, overstimulation can cause weakness as well. So again, the worse your patient's symptoms are, the more likely you want to go for the insulin. If the symptoms are a little more minimal, you might want to do the polystyrene. We can also educate a low sodium diet. They can actually do hemodialysis as well, but again, that takes a little bit longer as well because they have to put the catheter in to dialyze the patient. One other thing is when a patient has a potassium that's pretty high, one of the big risks that the patient runs as far as the cardiac monitoring is ventricular fibrillation. Now, ventricular fibrillation is where the patient's ventricles just do this. They don't squeeze like this, they just quiver. That's VFib. There's no way a patient can have a pulse with that type of heart rhythm. So that is dangerous. Okay, that's like, enemy number one as far as what we're worried about with hyperkalemia, along with cardiac arrest. So if you have a patient who has, EKG changes or the potassium is really high, one thing we can do is we can give them calcium gluconate. And what that'll do is that will kind of prevent that VFib from happening. So it'll kind of help calm the excitability down a little bit so that we don't get that VFib. Okay, we don't get ventricular fibrillation. There's some examples of some foods that are high in potassium. Obviously, I didn't do the high sodium food slide because we all know all the food that's high in salt, right? It's basically anything in the middle aisles at the grocery store. That's where all the salt is, okay? All your processed foods are full of salt. So you got to teach the patient to avoid canned foods, processed foods. That's the salt, okay? So potassium, it's the fleshy fruits and veggies and the green leafies. Those are the biggest. So fleshy fruits and veggies, so we're talking about potatoes, things that have a lot of flesh on them, potatoes, bananas, avocados, and then the green leafies like spinach. Okay, so those are the things we would definitely want to teach the patient. If they're low, you'd want to give it to them. If they're high, you'd want them to avoid it. Okay, now we're going to move on to our regulators and stabilizers. So the first we're going to talk about calcium. Okay, causes of hypocalcemia: decreased calcium and vitamin D intake. Lactose intolerance, let's not forget that one. Let's put that lactate up here to remind you guys that lactose intolerance is definitely a cause of hypocalcemia because a lot of people get their calcium in dairy products. Malabsorption, so this would be patients who have a hard time absorbing calcium, like Crohn's disease, for example. Kidney disease, there it is again. Remember, kidneys cannot regulate electrolytes when they are diseased or failing. And then diarrhea, we can lose calcium in diarrhea as well. A couple other ones. Let's talk a little bit about the parathyroid gland. The parathyroid gland are these four little guys that sit on the thyroid. The parathyroid gland's job mainly is to raise blood calcium. Okay, that's its main job. It has other ones too, but that's its big one. So its job is to raise blood calcium. So if you have a patient with hypoparathyroidism, that patient is not going to have the ability to raise blood calcium. So patients with hypoparathyroidism can actually develop hypocalcemia because they don't have their ability to raise blood calcium appropriately. Because the parathyroid gland, when blood calcium gets low, the parathyroid gland can increase GI absorption of calcium. The parathyroid gland can increase the amount of calcium that gets retained by the kidneys, and the parathyroid gland can pull calcium out of the bones and put it in the blood. So if it is hypo, or you have hypoparathyroidism, you can actually have hypocalcemia. Also, calcium and phosphorus have that teeter-totter relationship with each other. When calcium goes up, phosphorus goes down, and if phosphorus goes up, calcium goes down. So if somebody has hyperphosphatemia, they have too much phosphorus, this can happen sometimes like in renal failure. You can end up with hypocalcemia because the phosphorus levels are too high, and that will lower the calcium levels in the blood. Okay, let's move on to the symptoms of hypocalcemia. So when someone has hypocalcemia, calcium is not there to regulate and stabilize. So you're going to have those excitable symptoms like numbness and tingling, twitching and spasms. So this would be things like Chvostek's and Trousseau's. Chvostek's is where you touch the cheek and it reacts, so it's very easily stimulated. Trousseau's, you take a blood pressure, and just the stimulus of the pressure on the vessel, on the muscle of the arm makes the arm contract. Okay, so these are some of the excitable symptoms you can get. You also get cramping and diarrhea, more excitable symptoms. Then you have the symptom of the weak pulse. So that's one of those symptoms that doesn't quite follow the rules. But these are other symptoms you can get. So as far as the numbness and tingling go, the patient will kind of develop it in their hands and feet and around their lips and their face first. Those are kind of the first places that you'll see it. As the hypocalcemia worsens, then we start to get these spasms. When it gets severe, it can get to the point where you can get EKG changes and hypotension as the hypocalcemia gets more severe. Also, another kind of long-term effect of hypocalcemia. So if somebody has chronically low calcium, even if it's mild chronically low or mild chronic hypocalcemia, they can develop osteoporosis. So again, remember that has to do with that parathyroid gland. So the parathyroid gland is supposed to raise calcium. That's its job. So one of the ways it does that is if the calcium's low in the blood, it's going to pull it out of the bones and put it in the blood to maintain homeostasis in the blood. But if we do that chronically, we end up with osteoporosis. So that's another thing that can happen with patients with hypocalcemia. Chronically, though. Treatment of hypocalcemia. So if they are low on calcium, give them calcium. Calcium gluconate IV. Okay, so we can give IV calcium if we're really low or want to be more aggressive. PO calcium supplements if we're mildly low. Fix the cause if possible. I didn't put it up here, but that's an obvious one now, right? Fix the cause. Also, with the calcium supplements, you probably want to do some vitamin D as well, because vitamin D enhances calcium absorption. So you want to do that with the calcium. Now, as far as minimizing stimulations, let's critically think this one through. Why do we want to minimize stimulation? Let's think about this. They're very easily stimulated, okay? So we want to make sure we have a quiet room, a dim lighting, minimize visitors, soft voices. These are all things we want to do for patients that have hypocalcemia. We want to minimize that stimulation because they're so easily stimulated. Okay. Now we're going to move on to hypercalcemia. Causes of hypercalcemia: excessive intake of calcium or vitamin D, like excessive dairy. Thiazide diuretics. So far we've said that the thiazide diuretics seem to drop all the electrolytes. Well, it doesn't drop calcium. It actually raises calcium. The reason for that is calcium, thiazide diuretics actually cause calcium reabsorption. Okay, so they do actually raise calcium. So we got to watch. If you have somebody who has hyperkalemia, check their MAR. Do they have hydrochlorothiazide on there? HCTZ? That's what we're worried about. Hold it. Renal failure again. And then hyperparathyroidism. So remember we said the parathyroid raises calcium. That's its job. So if it's doing its job too well, we're going to end up with hyperkalemia. Okay. Symptoms of hyperkalemia. So we have increased heart rate, increased blood pressure. So these guys don't really follow the rule. So a lot of times cardiovascular doesn't always follow that nightclub rule of exciters and regulators. So increased heart rate and increased blood pressure. Now, if the hyperkalemia gets severe, the heart rate can actually go in the opposite direction. It can start going down. It's getting overstimulated. Okay, so we actually get the opposite effect happening if it gets severe. Blood clots in poor flow areas, so areas that the blood doesn't flow really well, the blood can actually clot when you have hyperkalemia, and that's because one form of calcium, which is ionized calcium, is actually part of clotting factors. It's part of a clotting factor. So the more you have of it, the higher likelihood of clots to happen. Then we have muscle weakness, decreased deep tendon reflexes, and decreased GI peristalsis. So these all follow the rules. This is a regulator. If he's too high, we're overregulated, and things are low and slow. Treatment of hyperkalemia. So a couple different things here. Loop diuretics, not thiazides now, only loops. Loops will drop calcium, okay? Normal saline will hemodilute. Calcitonin tones down calcium. Calcitonin tones down calcium. So calcitonin will drop calcium levels in the blood. Phosphorus, remember the phosphorus and calcium relationship. So if you increase phosphorus, you're going to lower calcium. Obviously, any meds that have have calcium or raise calcium, you're going to discontinue those and put that patient on a cardiac monitor. Very, very important, cardiac monitoring. And there's that relationship, calcium, phosphorus. Disregard those lab values. I think Galen lab values are a little different from that. Okay, calcium-containing foods. We have dairy, green leafies, nuts, soy, and fish with bones. So you can see them down here in the can, like sardines. Ooh. So we, again, dairy, green leafies, nuts, soy, like tofu, and fish with bones. Okay, so those are the things we're looking for. To tell the patient, again, if they're low, take it. If they're high, avoid it. Okay, we're going to move on to the final character in our story, which is magnesium. So first we're going to talk about the causes of hypomagnesemia. Malnutrition, you're not getting enough of it in your diet. Diarrhea, we're losing it through the stool. Malabsorption, not absorbing it. Diuretics, especially the loops and the thiazides, can drop mag. And then alcoholism. So too much alcohol use actually can change kidney function in the fact that it can change the way the tubules absorb. And so one thing that alcoholism can do is it can cause a malfunction of the renal tubule, which causes excess mag excretion. So again, basically alcoholism can cause the kidneys to excrete too much magnesium. Symptoms of hypomagnesemia. So if I'm not mistaken, all of these pretty much will follow the nightclub rule, which is the exciters and regulator rule. So if you look at this, mag is a regulator stabilizer. So if mag is not there to regulate and stabilize, we're gonna have like jittery type symptoms. So it looks like we're following the rule except for GI. So as far as the rule goes, sometimes GI and cardiac are the ones that don't like to follow the rule. But let's look. We have hypertension and dysrhythmias. Okay, that seems excitable. Painful muscle contractions, sometimes referred to as tetany, Tetany, tetany. Tetany can be very painful, and that's caused by that stimulation, that excitability. Increased deep tendon reflexes, so you reflex faster. Numbness and tingling, that's the tingly twitchy. Seizures and confusion with hypomagnesemia. And then decreased GI motility. So this guy doesn't follow the rules, but that can happen with low mag as well. Also, having to do with these muscle contractions, you can also get Chvostek's and Trousseau's with hypomagnesemia as well. Okay, treatments. What are we going to do here? We are going to treat the cause if we can. And if they're low on mag, give them mag. Discontinue any magnesium depleting drugs, so those diuretics, we're going to discontinue those. And we're going to give mag IV if we can. Now, one thing we want to make sure when we're giving back mag is we always want to check and see, are we overcorrecting? So remember we said here that the deep tendon reflexes should be increased if they have hypomagnesemia, right? So we want to make sure that when we're giving mag, we're going to be checking their deep tendon reflexes pretty regularly to make sure that we're not overcorrecting and putting them into hypermagnesemia. Because what do we think is going to happen to the deep tendon reflexes if we go to hypermagnesia? They're going to slow down, right? So if they're really fast during hypo, we're going to check them to make sure they come back to normal, but then we're going to keep checking them to make sure they don't start going too slow. Okay, we don't want the deep tendon reflexes to become decreased. We want them to be normal. Okay, hypermagnesemia. This is the last little bit here. So what's going to cause high magnesium levels? Too much mag intake. Medications, things like Maalox or milk of magnesia. These are drugs that have high levels of magnesium in them. Magnesium replacement, so giving too much mag. Remember we said right back here, IV mag sulfate, we have to watch to make sure we don't overcorrect. So if we overcorrect, we can actually cause hypermagnesemia. And then also renal issues, kidney disease can also cause issues with mag. So symptoms of hypermagnesemia, you see we've got this guy here who is lethargic. Okay, lethargy is a symptom of hypermagnesemia. Remember, this mag is a stabilizer, so bradycardia, hypotension, decreased deep tendon reflexes, muscle weakness, lethargy. These are all low and slow symptoms, right? And then we have EKG changes. So it's a pretty good bet to say that if your patient has an electrolyte imbalance, they better be on a cardiac monitor. High or low, any of the four. Obviously, potassium's the most important, but any of them. Cardiac is a major consideration. A couple of things that we have to worry about with muscle weakness. Anytime you see muscle weakness as an electrolyte symptom, watch the diaphragm, because the diaphragm is a muscle, and we do not want the diaphragm to be weak. Okay, how do we treat hypermagnesemia? So we're going to treat hypermagnesemia. We're going to DC all the supplements. We can give IV fluids to hemodilute. We can give diuretics to get rid of the mag, especially loops, or we can give calcium gluconate. So calcium gluconate kind of works like an antagonist to magnesium. I always say they're kind of like an old married couple. So you got mag and calcium, and mag is up here out of control. So you give calcium into the mix, and calcium's kind of like mag's wife. Calcium kind of comes in and says, hey, calm down, right? So when you give calcium gluconate, it kind of counteracts mag and kind of brings mag down a little bit. It's an antagonist. So calcium gluconate for hypermagnesemia. Magnesium-rich foods. So we're looking again at nuts, soy, green leafies. You can't go wrong with green leafies, can you? Seems like nuts and green leafies are the way to go, man. All right, well, that concludes my lecture on fluid and electrolytes. And take care.